Welcome, everyone, to another episode of Vega Insights. I'm Luke Bideaux, President and CEO of Vega Imaging Informatics. And with us today is Anthony Dispenziere from Reno Radiological Associates. Anthony is the CEO there, and he and I have worked together for many years at different practices. And so, Anthony, glad to have you here today. Why don't you just tell us a little bit about your radiology group?
Yeah, thanks so much for having me today. I've worked with this group now for about 10 years. Reno Rad is a independent fully hospital-based radiology group located in Reno, Nevada. We serve the largest health system in the region. We have about 100,000 square miles of catchment basin, and so it's a really big, geographically sized practice. But we focus really and concentrate in our area here in Reno. We have about 25 to 30 physicians plus 6 nurse practitioners and myself working to serve our local community. And it's a really fantastic group to work for. I'm lucky to do that, and I think we provide great service in great partnership with our health system that's called Renown Health.
Wonderful. And so we're here today to talk a little bit about the economics of medical imaging. And I thought of bringing Anthony on because he's got a lot of expertise in this area, and he understands, all the stakeholders and their place in the economic environment here. So I'm excited to have him talk about this and learn the imaging informatics community. While there are many brilliant people as part of the community doing great innovations, working very hard to keep the ship afloat at practices all over the world. I think many imaging informatics professionals may lack the education and understanding on the economics of medical imaging, which then can hold them back a little bit, especially if they're doing business ventures or trying to make a business case for a new technology that they feel, very passionate about. And so, yeah, I'm excited to dive into this. So, Anthony, why don't we just start with just some of the basics, some of the foundational concepts that one should be aware of when talking about economics of medical imaging?
Sure, of course. So fundamentally, you have patients coming in, they're either getting diagnostic or interventional work, right? In our case, we have neurointerventional as well as interventional. Those are procedural type stuff. But otherwise, the diagnostic read, which is usually the majority of the business, or at least a large portion of the business. And in either case, patient comes in and they're essentially, it's either the patient or the insurance, sometimes the government, sometimes commercial, is reimbursing the physician or I guess the entity that is providing that service on the basis of typically it's billed at a CPT code level. And so they're billing charges based on whatever services have been rendered to that patient. So simple example, they come in, they get an x-ray of their foot. There's a certain CPT code associated with that x-ray, and the bill goes out to insurance or the payer directly if it's self-pay, or I'm sorry, the patient directly if it's self-pay. And they basically, there are really two components to it. Typically, there's a technical component, which is the facility and staff. That's usually the much larger component. That usually goes to either an independent testing facility or more likely a hospital system or a hospital that you go into. And then there's the professional component, which is the physician labor that goes into whatever service is rendered. So the radiologist reading that X-ray gets reimbursed on the basis of a certain amount of work RVUs that are produced per different kind of scan. And so that radiologist, if they're independently owned, the radiologist is often independently billing either the patient or commercial insurance, and then the hospital is sort of separately billing for the technical side of things. Sometimes they're billed together, what's called global billing, especially if, say, for example, the hospital employs the radiologist instead and they're an employee of the hospital instead. Or oftentimes in an imaging center as well, they will bill globally for that kind of service. But that's the net effect is you're sending a bill to either a patient or insurance. And then, of course, often enough, they're using a billing vendor to try to collect the revenue from all of the service they provide. So at a simplistic level, that's kind of how the system is working and how money is flowing back either into the health system or the radiology group.
Got it. Okay. So as the patient, they find themselves paying their insurance premiums and their co-pays and things like that. And so the money is basically coming, from those insurance premiums to the insurance payers. And then I guess in some cases, when the government is shouldering the cost for the patient, it's coming, just from the government and tax revenue and things. And from the insurance payer level, these bills are hitting the insurance, right? Typically from is it the hospitals and imaging centers that are billing for both the technical and professional components, or do you sometimes see like the hospitals and imaging centers billing the insurance for technical and then the rad groups billing for professional?
It's both, actually. It depends on the nature of the relationship between the physicians that are working in the system and the health system. And so sometimes they send separate bills. Sometimes, even within an independent construct, you will, even though there'll be two bills for the professional and technical, maybe they're even being sent by the same entity. It really depends on the legal setup between the two. But ultimately, the net result is irrespective. You're getting money in for the professional and the technical components being billed to the insurance company. And yeah, they do obviously charge premiums to help support that. Health insurance companies these days make money in lots of different ways. If you look at some of their stock market returns and how much they're making, it's it's impressive how many different sources of revenue they can have. And so it's not just strictly from premiums alone, but that's certainly a large source of revenue that is then used to pay various claims on health insurance. You go get your CT, you're covered by your insurance company. They've authorized it in some cases, and they pay on the basis of what their contractual obligation is with that entity, be it the physician group or the hospital system. Sometimes they have different contracts. Maybe they pay the professional at one rate, the technical at another. Sometimes maybe they'll pay just the hospital, and the hospital will even pay either the doctor in salary, or if they're an independent group, they'll pay on a flat basis of X dollars per work RVU produced. Like the radiology group, does 100,000 work RVUs in a year, and they pay him a certain flat fee on that. And basically the hospital bills everything. So it really kind of depends on the arrangement between those entities and the legal structure involved. But net result, all the money is coming either from patients, insurance company, or the government for the work being produced. And I would say like 75-25 on average, technical versus professional. So a lot more of the money goes to the facility side. Obviously, that's also where the larger, more capital intensive side of the business is in terms of cost. And so that's the general nature of it.
And is it true that for a typical hospital, they have some specialties and departments that are sort of lost leaders where they're performing these things? They're not making any money. They're actually losing money. But most cases in radiology and in the imaging side, it's a revenue generating component of the business. Is that safe to say?
It can be, but I don't think that hospitals really look at this on an individual line item basis. I think in many respects, if you think about the call it market saturation of like if you a patient in a health system, right? I don't know what percentage of patients get imaging, but it's like 90+%, right? And so yeah, there are certain areas where CMS has decided they're going to reimburse more for, say, mammography these days than interventional radiology, which used to be the opposite. These are vagaries of sort of decisions that are made by the government that often have no basis in economic reality. It doesn't necessarily mean that interventional radiology is less value than now than it used to be. If anything, we need more of it. They're just paying less for it right now. And whatever political winds have shifted to, have mammography be reimbursed higher these days. That's sort of how it's occurred. But I wouldn't, it's an interesting circumstance with that.
Mm. Okay. And so is it always sort of this model where I guess the more services you provide, both technical and professional, as a practice, the more money you have coming in? Or are there other models? Like, what about some sort of managed care or value-based models that are, my understanding, a little different? Can you speak to that?
Yeah, I mean, I'm aware of those models. I've never really worked in them personally. I know there's a general concept of wanting to shift toward a more holistic view of healthcare in general, but all the groups that I've worked with still bill fee for service, whether they're billing patients and insurance companies, or they're billing the hospital for the fee for the service they perform. So I can't really speak with a lot of great example in alternate model, because I haven't, I've worked with 10 different physician groups in my career, and I've not seen it with any of those. And so I, I think I think maybe with certain ACOs, they're trying to work in that direction, but I'm not really sure that it necessarily functions that way on a large scale right now. I could be wrong. Maybe I'm speaking out of turn for areas that of the practice that I'm not personally aware of, but certainly in all the work that I've done, and I've worked in multiple states across the West, different independent groups. I haven't really seen anything other than the billing, the fee for service model.
Gotcha. Okay. All right. Well, I think that's a good foundation to start from. Now, I think the technology side of this is going to be of special interest for the listening audience here. So let's talk a little bit about the history of reimbursement or financial aspects of emerging technologies in medical imaging. Maybe not necessarily AI, but just new technologies that have come along. How does that typically work if it's something's new and there's not necessarily a CPT code for it? How does new technology like that get going with driving revenue?
Sure. So I guess it depends on the nature of the technology, but as you've mentioned, there often are not CPT codes in government or even commercial reimbursement for new and emerging technologies. I mean, specifically on the modality side, like if there's a new modality that is being tested, CMS will assign it a temporary code. Some payers may pay it, some may not, but that's very specific to imaging and procedural stuff. It's not really like an emerging technology, right? And so if you think about, just to use an example, some of the emerging AI tools that have come about, I think there's a clear distinction. Some of them are clinical in nature, meaning that they are helping to make clinical decisions about specific aspects within diagnostic radiology, and some of them are more process or procedural in nature. So, for example, we are implementing a smart workflow orchestrator, and that basically is a system where of information management where the instead of just having volume flow to seats, individual doctors that are working out on a work list, this kind of technology will reroute the work across our workforce so that the people who are best at reading, say, CTs or certain oncology scans, cardiology, based on your specialty, you'll get certain baskets of work, and it'll be more evenly distributed across the practice. Now, that doesn't necessarily require like FDA clearance, because you're not really doing anything clinical. You're just sending different types of work to different people, right? And so I think there's a clear distinction between the stuff that requires FDA clearance and is really clinical, and maybe in some future day would have a CPT code reimbursement, whether it come from like I said, payers or the government, or and sort of ancillary stuff that is process oriented. The process oriented stuff is going to come from basically will get paid for by a combination of if a independent physician group owns an imaging center and they want to like put on, say a smart full workflow orchestrator for their own packs, that just comes out of the till, right? The company will pay for it out of their own pocket, and obviously the revenue that's coming in, some of that is used to pay the cost of these new materials, of course, and then often enough, the technical component of the reimbursement is intended for facility. It's intended for IT and other infrastructure as well. And often enough, the hospital or health system is providing a lot of those resources. And so they will often enough be the entity that is investing in these various tools to make it cheaper, better, faster, to produce the work that is being produced. And so often enough, those, those entities will pay, but ultimately it's coming out of somebody's pocket to pay for these items because there is no separate stream of reimbursement usually associated with these kinds of new and emerging technologies.
Gotcha. Yeah, I was at a conference recently and it's kind of from the radiologist perspective, and they were talking about the golden goose, which is these professional CPT codes. I mean, that's for them, that's what it's all about, right? And any new technology that may fragment or take away the reimbursement, for the professional procedure codes, that really hurts them. And so they're very aware of what's going on in the political and financial landscape, watching those professional reimbursement rates, for those types of CPTs. And so I think that's an interesting perspective for the audience to understand, is that, from a radiologist perspective, they're really being driven financially by those types of professional service codes. And so if the technology is making them more efficient so they can generate more billing codes and get more reimbursement there, then that's a good thing, and there's value in that. If there was in the future a technology that fragmented their work in the eyes of the insurance payers and the government, for instance, I'll throw one out there, like all of this new AI assisted reporting, right? Because a big part of the case that a radiologist would make for his or her work is that I have to look at the images and then I have to create a report.
Yes.
And with the AI assisted report generation, it's like, well, but are you really creating that report, or are you just kind of editing it and
Sure.
finalizing it now at this point?
Right.
Maybe we shouldn't be paying you like we did before with generating it from scratch. Even though for many years, radiologists have been using templates, and they haven't been speaking out every single word anyway. But, technologies are advancing quickly with tools that can generate reports. They can even do some partial image interpretation and put findings right there in the report. And so payers and the government could see that as like fragmentation of the work. And so, that's where it might not be met with open arms by the radiologists if it means that, there could be some reduction in their reimbursements on the professional side.
Yeah, I agree with that. I mean, I think a lot of it is in the net effect and how it's, how it affects each individual person. I think it's important to take a step back and maybe look at some of the dynamics that are affecting the market overall. Very specifically, reimbursement on the physician level is capped, basically. CMS, there's budget neutrality on the physician side alone, meaning that if they increase somewhere, they have to decrease somewhere else, right? And so that overall reimbursement for the physician side of things has been going down dramatically in imaging. I think it's about, significantly less than where it was, say, 20 years ago. And so we have this almost deflationary pressure on the physician side of things. And the only way that you can make more revenue in a deflationary environment per unit is obviously to produce more volume. And so a lot of the tools do have that promise, like you mentioned, of trying to make it more efficient for the radiologists to produce more work so that they can, keep pace with all the other market effects that are, just general inflation and that sort. And the efficiency tools have a lot of promise, but we have a huge market constraint right now, right? Physician staffing is extremely limited, and there's a huge physician staffing crisis nationally. There are not nearly enough radiologists to perform the amount of work that's required as is. And the supply of radiologists is capped by the government that's training these folks. Obviously, government funding for that is constrained, and we're not training a whole bunch more people to take care of all this additional volume. You have the boomers sort of aging out, that generation. And so volume is increasing based on demographics alone, while a lot of those boomers were also radiologists and they're retiring. So you've got volume going like this. You got physician staffing going like this. and you've got reimbursement also dropping as well. And so these larger market forces at play are really squeezing physician practices in many different ways and ultimately creating these sort of weird, perverse incentives to do these various arrangements. So, for example, a lot of groups are now partnering, even independent groups like ours are getting closer with their hospital systems and entering into different relationships. In like, I think forever California has sort of led or been the lowest reimbursing payer market. And so, for example, radiology groups in California forever have been getting stipends of one form or another. There's various forms of stipends, but essentially the hospital is making a lot of money. Sometimes they get a lot of money from the government plus whatever they get with higher contracts. And they're basically giving money to the radiology group so they can survive in this super low reimbursement environment. And so the hospitals are also not capped politics. The hospitals are not capped by the sort of the budget neutrality. They can continue to charge. CMS will give them more money, just not the physicians. And so there's this weird game that's come up where the industry itself, more or less, is not able. That the market economics alone do not continue to support the industry. And so now all of the groups have kicked into this model where they're partnering with these facilities and they're getting a significant amount of stipend money so that they can run their businesses because the reimbursement itself just is not enough. And so those are sort of some of the larger market economics that are affecting and basically where has the money flow, so follow the money, right? Where's all the money going? Well, primarily it's going first and foremost to insurance companies, right? Within the industry. If you look at their Wall Street reporting, the fact billions and billions of dollars in profits, that's where so much of the money is going. Obviously, they have probably the largest lobbying effort and certainly most successful. And then secondary to that is the hospital lobby. The hospitals have, endless amounts of resources, significant amount of resources. They're competitive with the insurance companies with respect to the insurance companies are heavily consolidated. So basically they concentrate in a lot of wealth in a very, couple of companies. They have massive payer advantage, market advantage in that respect. But the hospital companies as well have a significant amount of capital, and they also have lots of lobbying efforts. And the individual doctors are extremely fragmented and don't have nearly the same amount of, leverage other than just the fact that they wear a white coat and they hope to get treated fairly by members of Congress, which unfortunately doesn't really always work out that way. And so you can see the political dynamics have really driven the market economics in our industry. And so I think that is, the high level, more money is flowing to hospitals and health insurance systems and less to physicians. But with radiology, if you don't have radiologists to support your hospital, you don't have a hospital, and so that's the reality is radiology touches 90+% of every patient that walks through the door. And if you don't have the staff to do the work, then you're in trouble. And so these hospitals are in a position of having to subsidize, because the government has been, unfortunately, harming physicians with reimbursement for decades, and the economics no longer support the business. And so now there's this sort of new arrangement of hospital plus reimbursement, or just, physicians working directly for hospitals, sometimes even working for health insurance companies that own hospitals. Talk about a conflict of interest. But there's all these weird market dynamics that have sort of evolved because of the market pressures with respect to the shortage and other things, plus unfortunately the reimbursement reality that we're dealing with as an industry. I can tell you that it's never been more challenging to be in a role like mine because there's a lot going on, and it's hard to, it's hard for scarce resources and not.
Yeah. A lot of the pain points you've touched on, similar themes I've heard from many radiology groups and practice managers. I want to learn a little bit more about the shortage of radiologists, because this is a theme I hear all the time. I know many of our viewers hear it. Why not just let more aspiring doctors and radiologists in through the door? And because I don't think it's a problem of not enough students want to become doctors and radiologists. You talked about capping it, right? And that's the problem why there's a shortage. So why not open it up a little more?
Well, ultimately, so if you wanted to start a residency or a fellowship, right? That's probably a 10-year process. Could be a little faster, but not likely, right? And you've got to think about where the money comes from to train these people, right? Because the net effect is you have people for years and years who will work to learn to be proficient in what they do that can never bill for their services because they're not experts. They're in training, right? And so it's very expensive to pay, somebody for living expenses, for all the education, all the other stuff, and obviously they're paying, on their side as well. But just generally speaking, it's expensive to train radiologists, and the government has not put a heavy emphasis on funding tons more programs. You can any number of reasons we are 39 trillion in debt as a government and other stuff. And there are various reasons why they may or may not have done that. But the net result also, there's like almost no physicians in Congress. So they don't, most politicians don't really understand much about healthcare in general, or specifically where the labor comes from. And so if you put all that together, you really don't have this concerted effort by the government to really start training more people. They certainly haven't been watching the demographic trends and saying, oh, we need to put more money in here so that 10 years down the road, we're going to be in a good spot. No, what's happened is they kicked the can down the road. They've been worried about whatever, political issues of the day. And unfortunately, we're in a spot now where the boomers are getting to a point where they really need a whole lot more healthcare services. And a lot of them are retiring and they're radiologists, like the percentage of, so like there's this metric in physician services where if you look at the number of providers in your practice over the age of 50, generally on average, that's the number of people you're going to have to replace in 10 years. And the higher the number of people above 50, the more at risk that industry is. And there's a lot of industries at risk. Radiology is certainly one of them. That's, probably above 50% of the radiologists are over the age of 50. And certainly with the amount of burnout that you're seeing from having to work harder for less money, people are just quitting. It's a combination of people just not wanting to work as hard as these radiologists are having to work to produce the work, and just not having the supply of them. So, I mean, if I had a magic wand, could I go back 15, 20 years and tell all the government people to put enough money in to make sure that we have enough trained radiologists to not have a shortage? Sure. But we are where we are. And now even some of the private equity groups are starting to fund fellowships and other things because they've realized that when radiologists attend a fellowship, they're more likely to stick around afterward. And so you're even seeing now non-governmental sources of funding some of these programs just because they'll take them by any means necessary. I mean, you need radiologists to get the job done, and there's simply not enough of them. The market economics, I think radiology is like, I don't know if it's like 1 or 2 or 3 among all of the specialties. Check out neuroscience, cardiovascular stuff, everything, like one of the highest paid, and that is continuing to increase just because of the nature of where we are, unfortunately. So that's what we're working with.
Yeah, we could go on for a long time. I want to give the audience a little bit different perspectives as well in terms of pain points, because you're coming from the perspective of a practice manager. You're very familiar with your pain points, but if you had to put yourself in the shoes of an insurance company, let's say, what do you think they would talk about in terms of their pain points and how the system is unfair for them? Because I get the sense that everybody has this case to make on how the system is stacked against them and they're barely surviving in spite of all of the challenges in front of them. So what types of pain points do you think we're hearing from the insurance payers and even the government, probably the largest insurance payer, right, for the US?
Well, the government in general is broke, right? I mean, 39 trillion in debt is nothing to scoff at. And unfortunately, it doesn't matter what political party you're from, both sides have done it. If you look at, if you look at inflationary spending, governmental wide, since I think the Clinton administration was the last time we had a balanced budget, and ever since then, it's some version of this. And so it's just a simple matter of spending way more than, in resources that we have. And a lot of that is in, like if you look at entitlement spending, like Medicare, Medicaid are, call them entitlements. That's where a lot of the government costs is flowing, because, more people need services. We're just seeing a generational trend, a demographic shift where we're going from a younger population society to an older one. And as that happens, more people use healthcare services, unfortunately. And that's just the nature of it. We don't, the money's got to come from somewhere. And, right now we have a Medicare program that's, you become at 65 and you're eligible. Right. And so the government services are going to go up just by the nature of the fact that so many more people are eligible and using them. That's on the government side. And it's real. I mean, but they also print money. So I can't do that. So they've kind of made their own problems, and they're not necessarily fixing them in a way that I would like to see, but the government has created this issue. On the insurance side, my violin's kind of small. You can barely see it. It's over here for how much I think they're really struggling. I think United Healthcare had a really bad year. I think they only made like $24 billion in net profit last year, which it's rough for them. When you think about where all the money's going in healthcare, if you look at numbers like that, and you're like, that is net profit that's going out of the healthcare system and going where? It's going to Wall Street, going to investors, but ultimately it's going to health insurance companies and it's going to their shareholders. That's a lot of money. $24 billion pays for a lot of stuff, and it's flowing out of the system, right? And so, yeah, they have all these regulations and stuff. Then they can say, oh, we're limited to do this because of that rule or this rule, and we're highly regulated, which is true. But the reality is they control the regulation and they like it the way it is because it benefits them greatly. They have by far the deepest pockets. They buy the politicians and they set up the rules themselves. There's only industry that you can think of where you have so many vertically integrated businesses that can all do business with themselves and have massive conflicts of interest that should never exist, that do not exist in other industries, because they have been able to navigate both sides of the aisle to ensure that they have set up the system for their maximum advantage. And that's who's making all the money. And that's why. I mean, they pay, just follow the money, right? Follow the lobbying money. And that's where all the money's going, right? And then secondary to that are the the large, certainly the multinational health, multi-state, national health systems. I mean, they have tons of advantage as well. All the nonprofits obviously don't pay any taxes. First off, there's probably the biggest business in the U.S. that doesn't pay, $1 in tax. And yeah, they do charity stuff and other things like that, of course. But let's suffice it to say they've got some significant advantages, financial and non-financial, and a ton of lobbying effort there too. And so the hospitals have challenges, of course. They have, I'll say this. I work with some really talented hospital executives, and I think they work very hard for what they do. I do think they do well. But I don't know that I want to be in their shoes. They're constantly fighting 10 different fires at once. And, healthcare these days is difficult business, right? So I don't begrudge them anything. I do think they do the best with what they've got. And they're really, certainly the folks that we work with are trying to provide the best care for their community possible. Are they disadvantaged to the extent that the physicians are? Generally, no, the health systems are not. They're in a much better position, I think, than the physicians are, even though, but that actually changes depending on what kind of health system you're talking about, right? If you look at rural facilities, they're getting hammered. I mean, I think they cut $1 trillion out of Medicaid, and now they're trying to give it back in tiny bits to say, oh, here, jump through these hoops and you can get a little bit of this money back. I mean, these hospitals, the rules subsist on Medicaid, right? And take that away from them, which is what is happening. And so many of them are closing. It's not, so the economics in that business, depending on the system and the support level and sort of where the money comes from, their payer mix is, can be wildly divergent. And unfortunately, you are seeing a lot of hospitals close. I don't know that I would personally want to live in a rural area if I were of a certain age, because your healthcare may not be around depending on how well or poorly your hospital health system is doing. And so those are things that people don't generally think about all that much until they have an emergency and they look around like, well, where the hell do I need to go to get healthcare services? But these are critical things that are affecting people's lives. And so, I mean, speaking about financial pain points in particular for hospitals, I'm sure there's myriad of them, and they're paying for a lot of this stuff because they know that we need it to be efficient at what we do, and it's better level patient care. To be honest, a lot of these tools that we're adopting are helping our doctors to be, better, faster, and certainly, things like if there's something detecting in the background that scans for strokes and scans for pulmonary embolism and other stuff that once detected, brings it to the top of our work list to our immediate attention to pay attention to triage immediately. That's a tool that is helping to save people's lives, right? And so there's definitely a healthcare benefit to it. There's an economic benefit in the sense of, doing more work with fewer people, which is just the nature of what we need to do to survive as an industry. So there are multiple layers to it, depending on the kind of technology you're talking about.
Yeah, it's complicated. And just when you think you kind of have a handle on it, you learn about new things that are happening behind the scenes or things you just didn't know about. And it's like, wow. I was at a conference recently about cancer care, and, at that level, pharma is such a big player, the cancer drugs. And, there was representatives from the pharma community, from the insurance payer community, from the hospitals talking about their perspectives on the pain points they have and everything. And it just seems like it's good that there are checks and balances, but everybody's just defending their best interests rather than all of us collectively looking for a solution that's best for the patient.
That's true to an extent. I would say that the doctors these days are so damn busy that they barely even have time to defend their interests. I mean, if you're a modern practicing radiologist right now, like, these are some of the hardest working people I have ever met. I think they do fantastic work with the limitations they have. I'm constantly in awe of what they do. And for anybody that thinks that doctors make too much money, I don't think they generally know what they're talking about. Because if you look at the nature of reimbursement trends and the amount of work that these guys and gals are producing to serve their communities, it is very much a service oriented thing. And that's a big part of the reason why we're losing a lot of people is they're just burnt out from how much work they're getting crushed with. And that's if you can find the doctors to do the work, which a lot of communities are struggling with. I wouldn't want to, like, I've worked in groups across this country, and some of the harder to recruit for areas are really severely disadvantaged with lack of physicians and physician access, getting access to healthcare. I mean, it's materially impacting people's lives in unfortunate ways. And so it's difficult to see that. We're obviously just mainly focused on doing right by our physicians and giving them the best possible working and living, collegial experience to ensure that their lives are as good as they possibly can be, because that's what keeps people around. I think our group is exceptionally good at that, at trying to focus on the individuals, mainly because it's owned by the doctors. The doctors are doing right by themselves as best they can. Are we perfect? No, I don't think anybody is, but I think we do a pretty good job of trying to defend our interests, at least with respect to our localized stuff. But are the doctors engaging on the state level nationally to really move the needle in their favor? Generally, no. And I would say that they don't necessarily have enough time or effort, resources to do that. I try to go and talk occasionally at our state capitol just to advocate on the behalf of our physicians. And, I'm probably the only person that has time to do that. And I don't have a lot of it, but I do what I can.
Yeah. Well, so many challenges, and I think what we often hear the solution is going to be is AI. Right? AI is going to save the day and make everyone more efficient. And that's going to be the answer to the radiologist shortage. That's going to be the answer to low reimbursement rates. It's going to be the answer to everything. And obviously, reality is somewhere different than that. but maybe there is a place for AI to help with the problem. What do you think about like the short term outlook for AI helping with some of these problems, and then the long term as well?
Sure. First, I just want to frame it a little bit. And so if you go back 20 years, 25, 30 years, somewhere in there, we had radiologists that were working before PACS. And I'm sure your audience probably knows mostly what PACS is. But they were hanging individual films, taking pictures, putting them on light boxes, reading study by study. They didn't have an information managing system to digitize the information, to be able to look at things efficiently, to be able to report more efficiently. Nothing was really digital. It was more manual, right? And so we had radiologists working pre-PACS, and a lot of radiologists were convinced that PACS was going to be the end of their profession. They were going to lose their jobs. Well, if everybody can see the images, then what the hell do they need radiologists for, right? And lo and behold, you know what PACS really did? PACS made us efficient enough to buy us about 20 years of efficiency. So we were able to keep up with the work volume enough to be able to get the job done. But PACS, the efficiency gain from PACS is basically has run out of steam. We've seen it. It's been fully implemented. That efficiency gain, the sort of the improvement has fully tailed off. We're hoping that with the tools that AI can provide the radiologists, that maybe we can buy some additional incremental amount of time like PACS did to help us to get the job done. If AI lives up to its promise, will allow radiologists to read enough studies and do enough work so that we can treat the patients we have in our community with all the various imaging demand. Imaging demand is skyrocketing, right? There's only without enough physicians to throw at it, you got to be able to manage the volume somehow. The only hope we have is AI. That's where we're at, right, as an industry. And so it's critical that we get these tools so that we can continue to deliver on that, on our obligations to be able to read the work that needs to be done to facilitate everything else that goes in a health system. I'll just give you an example. If you have interventional radiology, right? If interventional radiology as a practice is not particularly highly reimbursed on the professional side, but if you look at all the downstream effect from it, you don't have a trauma program without IR. You don't have a pediatric program without IR, and you don't have an oncology program without IR, right? And if you think about the downstream effect from radiology, it's practically everything in medicine. And so you can look at the individual reimbursement and say, oh, this is a loss leader or not, but you're really talking about the whole enchilada because without radiology, you don't have healthcare. You don't have a health system, right? And I know it's only one component in a much larger healthcare delivery center, but the nature of the economics have put us where we are. And as an industry, we are vital, certainly with everything we've discussed, we are vital to the future success of healthcare as a business. And so that's kind of, maybe I've gotten a little bit off of where I was headed, but I wanted to sort of talk about some of those dynamics.
Well, it's been a great conversation, and we're limited on time, so I want to wrap up with just one final question for you. What are your thoughts on fully autonomous AI in radiology? Would it be the end of the world if certain types of exams did get there with fully autonomous reads? We've seen it in ophthalmology for a number of years with diabetic retinopathy screening, AI doing the fully autonomous final interpretation. Do you think there's a place for it in radiology at some point in the future? And what would the effects be?
I will tell you that it already exists now. It just depends, just not in our country, right? I would tell you that AI and fully autonomous radiology work in a third world country is way better than having nothing. And so you're seeing, in countries that don't have developed healthcare systems, you already have it. And obviously we have a very US centric perspective. It's where a lot of the healthcare spend goes, and certainly where a lot of the attention and focus is. But that already exists. And I think you're seeing more of it as there's, I think the UK is looking at x-rays and some of the other places as the shortage is different in different places. It's more severe in certain places. They're doing everything they can to at least have something which is better than nothing, right? That doesn't mean it's good medicine. That doesn't mean it's a good idea necessarily, but it's better than nada. So it already exists now. And then the question in my mind is, how far down the road are we going to get to the point where we need to start adopting these kinds of things because we just don't have the ability to do enough work to meaningfully treat the patients in our communities. And I don't think the US is there yet. I don't know that we will be. And the other thing that impacts a lot of this is the medical legal side of things, right? Right now, the reality is, first off, by nature, our is 20 years behind the times in the US. The FDA mandates that in a lot of respects because you don't want new technology killing people. You want to see it in, some less impactful industry, the good, bad, and the ugly, to sort of see it vetted and then learn from it and then apply it, right? And so I don't think healthcare is ever going to be a first adopter or an early adopter in a lot of this technology. We're using it incrementally in places where it makes sense. And I think the FDA is clearing, but the FDA has their own limitations, right? I think you'll see, depending on the country, right? That's going to be the degree and the specific, situation in each country is going to sort of dictate part of it. And then the medical legal, like the doctor signing off on the report means that you can sue that guy if something goes wrong, right? I don't see any AI companies anytime soon be like, sign me up for that deal. I'm going to start, like Mark Zuckerberg is going to say, oh, I'm going to sign everything. And so like, just sue me for everything, right? That's ultimately, I mean, the U.S. is a litigious country. That's part and parcel of it. And so until the point where the AI is either going to take on the liability or the politicians are going to absolve them maybe of the liability of the work that they're doing. I mean, AI hallucinates. It's really good at Where's Waldo. It's really bad at that kids game where the dog is on top of the airplane holding a wrench. Like, it doesn't know why the dog is, it doesn't make any sense, but like, it couldn't tell you anything about good or bad, right? So it's great at certain things. It's horrible at other things. And maybe at some future point, we'll get to the point where AI is so good at everything that it also kind of takes this over. I think the notion of AI taking everything over is quite overblown. Maybe not eventually, but timing wise, right? Maybe not in the next 5 years, 10 years. After that point, I can't predict, right? But I know right now, autonomous AI reading stuff. I mean, hell, we have it helping us now, and we have to check everything to make sure that the AI isn't hallucinating or saying something that is wrong, which it does sometimes. And your license is on the line if you sign a report that says, oh, AI said this and I didn't check it, right? So nobody's doing that, right? It's gotta be beneficial for the patients, and it's gotta make sense medical legally. So that's a long-winded answer to the question, but I don't see it happening anytime soon in our country specifically. Maybe.
Yeah. Well, always a pleasure to get your perspectives on things. And, it's been great having you on the show. So I just want to thank you for your time. And I just want to encourage the listeners out there to go ahead and subscribe to our YouTube channel. And we'll look forward to our next episode. So thanks, Anthony, for being with us. Have a great day, everyone.
One thing I'd say, if anybody wants to reach out to me about anything in particular, you can find me on LinkedIn, and you've got my name on here. I'd be happy to help people with questions. I don't know if I did that in the right order sequence. Sorry, but I was going to say that.
Perfectly fine. Yeah. And always open on my end as well for any questions. So thanks, everyone, for watching.
Thank you.